Hi, everyone. Thank you for joining today's webinar session. My name is Maya Mendez. I'm the Telehealth Program Manager at the West Health Institute. In this session, Dr. DeCherrie will provide an overview of the hospital at home model and share how Medically Home is delivering patient-centered telehealth care for older adults. This will be followed by a panel discussion with experts in the hospital at home program. So today's speakers are members of the Collaborative for Telehealth and Aging. We're joined by Dr. Linda DeCherrie from Medically Home, Dr. Bruce Leff from Johns Hopkins, Rani Snyder from the John A. Hartford Foundation, and the panel discussion will be moderated by Dr. Kevin Weiss from UNC Health. So I'll go ahead and hand it over to Dr. DeCherrie.
Thank you. Thank you all for joining today. As was stated, I'm Linda DeCherrie. I am a geriatrician by background, and I have been working in the home-based space really since I finished my training, working in home-based primary care, home-based palliative care, and then most important for this talk, in hospital at home. I'm currently the Vice President Clinical Strategy and Implementation at Medically Home. It's a company that partners with health systems to co-operate hospital at home. I'm going to really speak today in more generic terms about hospital at home, and then I will mention some things that are specific to Medically Home, but as I said, mostly in the generic terms. So this is a little bit of a history of hospital at home. I'm not sure, those of you on the call, how much you have kind of dived into this in the past, but hospital at home is actually not new. It was started in the 60s in France, and then it was in many other international countries in the 70s to 90s, such as Canada, Australia, Israel, United Kingdom. And then we're lucky today to be joined by Dr. Bruce Leff, who helped start the first hospital at home program in the United States in the mid-90s. In the early 2000s, there were some of the first publications. And then where I was at prior to Medically Home, which is at Mount Sinai in New York City, we got a large CMMI award to implement and study hospital at home with the Medicare fee-for-service population. After that, there were some, of course, some great randomized trials that have come out of Brigham and Women's, and now MGB. And then in 2019, a group of us started something called the Hospital at Home Users Group. I'm going to explain a little bit more about that at the end of my talk, but that's a really important resource for those who are operating hospital at home programs. And then to get really to the title of the talk, which is the pandemic and post-pandemic, what did make a big step forward in the hospital at home movement was a payment for hospital at home, which was one of those unusual benefits of the pandemic, in that CMS decided to pay for hospital at home on par with inpatient medicine starting in November of 2020. Specifically for hospitals that applied for a waiver to do so. And as of today, there are 330 hospitals that have been approved for that waiver in 37 states. So this is a little bit of definitions of hospital at home. I mean, really the key thing is that hospital at home is inpatient care. And this definition came about from the World Hospital at Home Congress, where there's also different international flavors of it, but this was the definition that was really agreed upon, that this is not outpatient care, this is not chronic disease management, this is not patient monitoring, this is not home-based primary care or home health, but this really replaces inpatient care that's episodic, provides all that inpatient care, it provides a 24/7. It's hospital directed or provided by hospital level physicians. And specifically for the waiver in the United States, meets the regulatory and governance obligations of hospital care, and then consented to by patients. So what does this actually look like? And I'm going to speak mostly in terms of the waiver, where patients have to come from a physical hospital. That is one of the requirements currently. If you operate a program directly with an insurance reimbursement that's not through Medicare, you have other options of taking a patient from urgent care or from home. But on this slide, I'm focusing on the waiver where patients need to either start off in the emergency room, or maybe they needed to spend a night in the brick and mortar and they're identified on the med surg floor, or maybe they came in for a hospitalization that has a post-op hospitalization day or two. And those are also patients that could come potentially from the PACU. Then you need to, make sure you have a valid reimbursement source, that you're in the geography you have set up all the services for, that they meet inpatient criteria. Most programs do some sort of tool to check for clinical stability and social stability. And then, as mentioned, that the patients have a choice. And then you really have to think of it as providing acute inpatient care, almost everything that would be provided in the brick and mortar. The one difference is not a nurse literally next to the patient 24/7 in their home, but instead that there's a ability to reach the providers, that there's 2 in-person visits every day at minimum, that there's nursing assessments throughout the day, and that patients get their labs, they get their medications they need a home health aide. All of those services need to be provided in the home. And then, similar to any other hospitalization, I wrote day 5. I think even hospitalizations today are even shorter on average. But at whatever period they would normally be discharged in the brick and mortar, you would follow the same criteria and discharge them and have the normal discharge planning process and discharge plan, follow up with primary care or other outpatient services. So what does this look like? So this is a more medically home specific slide, in that we think of it in 3 kind of buckets, that there's a command center that manage the patient remotely. Those are physicians who do daily video visits. There are nurses 24/7 in a command center who are available to the patients. They are doing the exact same nursing assessments that are done in the brick and mortar, but they're doing it remotely. So the normal falls assessments may be enabled by someone in the home. They're doing all the pressure ulcer assessments, all of those normal things they are doing. They are witnessing every med that's being administered. So 5 rights and documentation on a medication administration record. And then there are usually APPs involved, and they can have a variety of roles. They could be helping to identify patients. They could be helping the physicians in their management of the patients, just like they might in brick and mortar. And then some programs also have APPs who can go to the home to help facilitate care at that higher provider level. And then if you go to the right, you see all the things that have to be done in the home. And so that is really, the mobile x-ray, the ultrasound and EKG, all the labs, x-rays, oxygen, everything that needs to be happened in the home, and creating the right service level agreements with those companies, because usually the health system cannot supply all of those things themselves, to make sure they happen in the right time frame. For example, it's often okay for PT to happen later that day or the next day. Well, if you need, a stat EKG, you need to be able to do that within a couple hours. So those are kind of different service levels you might be coordinating, and making sure that's all coordinated and getting to the home. And then it's creating the technology to fit all that. Almost all of the programs we know use the normal EHR from their health system. We at Medically Home have a technology that integrates with the EHR to help translate those orders into the community. But other programs are doing it straight out of the EHR and able to coordinate those logistics into the home in just a different format. And then the last part is that technology in the home. What does the patient see? And I have a slide coming up. I will show what we do. I would say most programs today who operate hospital to home have some sort of video capability with the patient in the home, but not all. It's not a requirement. You just need to be able to have a quick ability to reach the patient or them to reach you in these programs. So this is, what a command center might be looked like, and it's really how, you might be able to do all the logistics and coordinate, for the patients in the home. But then, I've been spending a lot of time on that part, but the in-home is just as important, that bedside coordination. And so being able to do that 24/7 and have the equipment in the car, because you may not always realize what you need for a patient until you're actually there. And so that's why nurses and paramedics who might be doing those in-home visits are often equipped with technology such as point of care lab testing, the EKG in their car, potentially some medications, a formulary in their car as well, so that they can administer things quickly for the patients. But of course, all under the direction of the physicians, APPs in the program. So this is the technology. This is specifically, again, what Medically Home has, but again, many other programs have something very similar. So a tablet, a way to reach the patient where you can do video. Medically Home thought very carefully about what is curated here to think through of the population that we're going to serve. So we're talking about older adults, but also younger adults who might be at that moment really not feeling well. So how do we make sure that everyone is able to reach us? There might be people with mobility problems. There might be patients who have hearing or visual problems. And so this was all designed thinking about all the different patients who might come into the program. So large button down there to talk to my team, large font with a schedule that everyone can know what's going to happen. And then we have specifically what looks like a landline phone, again, very familiar to some patients. And if you pick that up, no dialing needed, you reach the command center nurse. And so that was something that has proven to be often the first way that patients contact their team. Then a PERS device, so that when they're not near the tablet or phone, they can still reach the command center either by a necklace or a wristband. And then the typical peripherals such as a blood pressure, a scale, a pulse ox, a thermometer. And then on our devices, we have a backup battery in case the power goes out, and then don't require the patient to have Wi-Fi. So that's a router there that can access a variety of cellular services. So thought about this long and hard for the patients we're trying to reach. So where are we right now with the waiver? So as I said on that timeline slide, there's 330 hospitals in 37 states. So that's already, a big number of you're thinking about the diffusion of innovation, like where we are in the movement of this. Where just to give the background of that, the waiver came about during the pandemic, was extended for 2 years, so it will end at the end of this calendar year. But there is a lot of discussion about a 5-year extension. It's gone through some committees right now in the House and Senate, and we're going to hopefully we'll be able to have a 5-year extension to that. It is tied right now to the telehealth other rules, and so maybe that will be a nice movement forward to have those kind of paired together. And then to give you some resources, so we put together a case study on the Center of Excellence for Telehealth and Aging, who is sponsoring this webinar here. We put this together, which gives more detail of how we came about with the technology. And that might be a useful resource for everyone to look at as you're thinking about maybe starting a program, or as you might be kind of adapting your program. The Hospital Home Users Group. So I mentioned this also on the first, on my timeline slide. So the Hospital Home Users Group, 4 of us started this thanks to the John A. Hartford Foundation. And it is provides free open source technical resources for hospital at home programs. It has, we have webinars, we have an annual meeting, and we have a lot of resources on the website. It's free to join. So I would definitely recommend that as a resource to look at for as you again start, or maybe update your hospital at home program. And then the last website is, of course, CMS's website related to the waiver, which you can find fairly easily. So with that, I'm going to open it up to Q&A.
Thank you so much, Dr. DeCherrie, for really succinct, informative presentation about what hospital at home is, and how it works at a 30,000-foot level. What are some of the barriers? So it's one thing for a hospital or a healthcare system to get the waiver. It's another thing to make it happen. And so what are some of the barriers to implementation of hospital at home? I think specifically thinking about from a hospital setting to, say, medically home service line. What are some of the barriers of that being available to as many patients as possible?
Yeah, I think that is probably multifactorial. So one is just the payment, like you mentioned, right? So, if you have the waiver, Medicare fee-for-service patients, but that might not be the predominant insurance for your health system. So there's Medicare Advantages, commercial. In many states, there's, I think right now, only 10 states maybe that Medicaid pays for this. So that would be one, barrier, is to try to obtain the insurance coverage for all the patients who come into your health system. But you're right, even if you had all insurances, there still is a barrier to how these programs are implemented. And one of the key things is this really can't be a side little project in the health system. It really needs to be front and center if you're making this, a significant play in your health system. What is the reason why you're doing this in your health system? Are you at capacity? Are you trying to open up beds? Are you maybe interested in a new service line, surgery, oncology in your health system, and you want to see if you can open up a wing and have some of these more general medical patients have the option of being home to open up for that new service line? And if that's the case, then it has to be a significant effort of the health system. Where this fails is when the one particular specialist says, no, my patients can't go, or I need to always do the consult the next morning. Patients only stay in the hospital 3 days, on average 3-4 days. If you are already going to wait a day or two for that consult, then you really, now the patient's upstairs and is going to be discharged a day or so later. And maybe the effort is different than if they're sitting in the ED. And so it needs to be an important initiative. And so that's change management, to have everybody realize that this is now a new virtual unit of the health system. I would say that's probably the biggest barrier, because you can really work through all the workflows of how to bring someone back for the CT scan, how to get all those things, as long as you just map it out and know where to bring people at the right time and coordinate. But the physicians, this is different than what we were trained to do, how we've been working, and to be honest, most of the outpatient providers in the pandemic did a lot of video visits. Hospital medicine didn't do a ton of video visits. They may have worked in a transitional program or done the virtual ICU, but I'm saying in general. And so this is different for them to be doing consults and the care of the patient all virtually. And that's a change for everyone that they have to practice and get used to.
It is easy to underestimate the power of inertia.
I'm excited for when we have trainees who have seen these programs and they're then become the attendings. I feel like, that change we don't need to wait for that, but at that point, I think we will get to this place where it's going to be just something that we have in almost all hospitals.
Awesome. No, it's incredibly exciting. I want more of it. Hence Hence, I'm excited by these questions. And here's one more question that came in from the audience regarding your presentation. What do you think is the main driver of cost saving? So the essence of the question is, if hospital at home is really hospital at home, then at least in theory, you're losing the efficiency of consolidation of resources. Like you have to send, one of the pictures was of a car, which means somebody's driving somewhere, which means there's windshield time, which means, you don't have one bank of monitors, you've got monitor things everywhere, you've got stuff dispersed. You're losing the efficiency of everything being in the same place. And yet, clearly, there's pretty good data that at the end, this can be cost saving. What drives that cost saving? If you accept the premise that there's a lack of some sort of consolidation effect and some sort of efficiency from losing that consolidation effect, then how do you offset that? How do we still drive cost savings?
Yeah,
yes.
That's a great question. So I'll start with a couple answers. One is it's clear that if you look at the kind of 30-day episode of a patient, that there's definitely cost savings there. We've shown that patients have less readmissions, less ED visits in the 30 days, and less SNF usage. So all of that is going to be a clear savings to a health plan, to the insurance for these programs. And that's really how the model was envisioned when I was at Mount Sinai. It was a 30-day episode. The pandemic and the waiver is not that. It is just the inpatient part of this. So if you just take that inpatient part, you're right, there's windshield time and higher personnel costs potentially because of that windshield time, but you don't have the overhead of necessarily of the hospital, right? A hospital bed is $2 or $3 million to build. And so if your choice is hospital at home or another wing of your hospital, that's where you start to see some of those savings in that. But you do need to have efficiencies of those providers in the home. You can't, this is where programs that are, with 5 patients in them, it's very hard to have that efficiency. Once you start to have 15, 20, 25 patients, then you have enough kind of redundancy out there of everyone doing their thing every day, and potentially some dedicated staff, some flex staff. It really, that's where it starts to come together as being cost neutral or cost savings to those health systems.
Awesome. Thank you. And how much, you alluded to this, but with the CMS waiver focusing just on the inpatient admission, I should drop my use of quotes. It is a real inpatient admission, no air quotes required. Then do we know whether we're losing any of the redundancy of efficient, whether patients are coming back to the ER more than under models where they had more thoroughly followed them out for those 30 days? Do we lose some of the increased savings through decreased utilization downstream?
We don't know the answer to that yet. There is in those original randomized trials in the US that David Levine did, he did not do a 30-day, and they did show the reduction in ER and 30-day readmissions. So that would support that we don't lose it, even with the not having the following of the 30 days. But I think we may lose a tiny bit of that. We know that transitional care is so important for patients.
Yeah.
And health systems have a variety of services related to that. Even though we envisioned when I was at Mount Sinai this 30-day episode, and it's the continuity of the same team is really key, but it is not the only way to do it. If a health system has a very robust transitional care program for the right patients, that could be tacked on to a hospital at home program as well. And probably be, pretty closely equivalent. It's really all about those handoffs.
Awesome. There is one more question from the audience about the role of the caregiver, but I think I'm going to use my moderator discretionary powers here and decide that that's a really important question that we're going to ask to the panel.
Sounds great.
Take Dr. DeCherrie off the hot seat for well, at least to share the hot seat with others. We're not actually removing you from it. We're just putting other people on it as well. And maybe we could switch over to the panel discussion part of this as per the slide. And if the team would like to come off, yes, come on camera. That would be awesome. Fantastic. So I have a few questions for you all. Thank you, by the way, thank you for putting up with me. I feel like I'm swimming in jello a bit today. I was post overnight in a very busy hospital shift where we could have done better were we sending more patients to hospital at home. I believe that is true. I believe patients would benefit from that. I believe it would open up some capacity, which we desperately need. And ironically, we have the waiver in our system, and we have Medicaid support, and we have a lot of room to grow as far as, let's say, consistent utilization. So appreciate everything you're doing and appreciate your tolerance of my my sleepiness, if you will. So a couple questions, and this first one I'm going to ask to Bruce. Bruce Leff, who has helped put hospital at home on the map in the United States. He has been, in my perception out there, sort of the prophet in the wilderness in the United States, calling for this for a long time. And finally, people are indeed, if you'll forgive the analogy, coming to the river. Bruce, thank you for everything you've done to put hospital at home on the map. Of course, at West Health, we're uniquely interested in the needs of older adults, and particularly those with chronic condition, cognitive impairment, frailty. Bruce, how does receiving care at home improve the overall patient experience as compared to traditional hospital settings, particularly, again, for those older adults, chronic conditions, frail, limited mobility, et cetera?
Thanks, Kevin. And just by way of introduction, I'm Bruce Leff. I'm a geriatrician, primary care geriatrician and health services researcher based in Baltimore at Johns Hopkins, and appreciate the shout out for work we've done over a number of decades. But if we were the prophets, then, you know, no profit operates without support, and that support came from the John A. Hartford Foundation. So we've been deeply appreciative of that support now for decades, and it takes a long time to get health services implemented and scaled in this country. And that would be a nice topic for discussion as well. I think you started on that with Linda. But, you know, to your question about how hospital at home can help older adults, that was actually the original reason we started to think about hospital at home. So when I was starting off as a resident and then ultimately as an attending, one of my clinical experiences was doing home-based primary care. So primary care, longitudinal, in the home for older adults who were too frail to come into our outpatient clinic. And it was not at all uncommon for those patients who had multiple chronic conditions and functional impairment and often limited social capital to develop an acute illness requiring a hospital stay. And we saw two things happen. One, they would go to the hospital and often suffer iatrogenic complications from being in the hospital. That is, occurrences like incident delirium or an acute confusional state, which can contribute to ongoing chronic cognitive impairment, loss of functional capacity. So someone was living at a home and then ultimately needs to go to a nursing home, adverse drug reactions and the like. And then on the other hand, you know, folks who would flat out refuse to go to the hospital. So there's a gentleman, I still carry a slide of a gentleman named Walter, who was in our home-based primary care program, needed to go to the hospital for pneumonia. He had multiple chronic conditions, and we're at his house and said, Walter, you need to go to the hospital. And he said, you know, and I'll never forget this. He says, I am so sick and tired of you geniuses from Hopkins. You're great doctors, but you run a crappy hotel. And I'm not going to the hospital. And this is your problem. And it was those kinds of instances that really got us to think about hospital at home. That said, when we did our early clinical pilots at Hopkins and then ultimately a larger study in several Medicare Advantage plans around the country, we focused very closely on important geriatric complications like incident delirium, like functional capacity, like adverse drug reactions, like restraints being applied to people in hospital. And what we found was that if you're taking care of it at home, your risk of getting delirious is reduced by about 75%. Your mortality rate was lower. Use of sedative medications was markedly lower. So that was really what motivated us to move into this space. And I think that, you know, as much as it can help older adults, it can help people who are younger, who simply would prefer to be at home rather than, you know, the total institution that is the hospital. And also just to, you know, a clarification, I don't think any of us who are involved in hospital at home are Luddites. You know, we believe that hospitals are necessary and that they also do a lot of good. And no one in the hospital at home movement is saying do away with hospitals. But I think what we are saying is that hospitals have been around for a long time. If you look at the history of what takes place in the buildings that are hospitals, that has changed a lot over time. And, you know, my own sense is that hospitals of the future are going to be big, you know, Full Employment Act for you, Kevin, big ERs, ORs, and intensive care units. And much of what happens now in the hospital will move out to the home and the community. That's what I think will happen. I don't know the lag, but I think that's where the future lives.
Thank you so much, Bruce. Really appreciate all of those comments. I'll confess that I sometimes say that unless you have a condition that can only be fixed in the hospital is no place to get well. And maybe that's a bit flippant, but it is a hard place to recover in, given sort of the space you're in. And 75% reduction in delirium has profound implications in the well-being of our patients. I have failed to give everyone else an opportunity to introduce themselves as we transition into this. Dr. Leff had to agilely slide his own introduction in there, but I'm going to try and spare Rani Snyder the pain of having to slide in her own introduction. So Rani, could you introduce yourself as well and remind us all who the John A. Hartford Foundation is and why we're so lucky to be partnering with you on so many great initiatives?
Thank you, Kevin. I am Rani Snyder, and I am the Vice President for Program at the John A. Hartford Foundation. And that means I have purview across all of our programs. So we're really proud to be working with all of the folks who are on this panel today. Our mission is to improve the care of older adults. We do that nationally. Although we're located in New York City, we operate all across the country. And I guess the last piece I'll mention is that both Bruce and Linda already referenced the fact that our foundation has funded the hospital at home model since the 90s. It's been a long running partnership. We are huge fans. We'll cheer on the work that they're doing, and we continue to support this work given the incredible difference that the waiver has made to the number of sites that can offer care, to the kinds of care that can be offered. And now, as we're here today talking about various forms of technology, including telehealth, we're really proud of the work that all of this group is doing.
Awesome. Thank you very much, Rani. And again, as it's been alluded to, thank you to John A. Hartford for making so much of this possible for so many years. Tremendously appreciated. Rani, I'm going to keep, since I asked you to join the hot seat, I'm going to follow up with a question for you. And this question was actually something we thought as a group we should ask during this webinar. And then one of our audience members just spontaneously asked a different version of it as well, which is, talk to us about the caregivers. What do we know about the caregiver experience of hospital at home, perhaps of hospital at home as opposed to hospital at a hospital? What do we know about anything about like, are there advantages to being a caregiver in that situation, disadvantages, or even what are the right questions we should be asking? Because a patient is not a solo entity. Most of the fortunate ones travel with some sort of caregiving team. And how should we be thinking about their needs during this experience as well?
Thanks, Kevin. I saw that in the chat also. That was perfect. What a setup. So, I'll start by saying first, it's really important that we acknowledge that when we're talking about improving care for many patients, and often especially for older patients, we really have to consider the needs of family caregivers. Otherwise, it's not what we call age-friendly care. And so I wrote about this in a Health Affairs Forefront article with family caregiver advocate Carol Levine, who thinks a lot about family caregivers in general and with regard to hospital at home as well. And so secondly, I really do want to note that we need more research in this area. We have some clear ideas and knowledge about what is happening and what is helpful. And we need to study it more closely. And that's part of why with our most recent grant that we have funded among many grants over time to this work, we, the John A. Hartford Foundation, have included support for qualitative research on the experiences of and the needs of family caregivers, as well as underserved populations generally. So third, the evidence we do have seems to indicate that family caregivers fare pretty well. They fare as well as caregivers of patients in hospitals. And I do want to say, to sort of a sweeping question, there is no one only and right answer, because patients are vastly different from each other, as are caregivers. No one caregiver experience is quite like another. But I'm going to cite a few studies that we do know about. So one small but important study, it just has 42 patients and caregivers, but it was published quite recently in 2023 with another of our partners, by another of our partners, David Levine and his colleagues, looked specifically at caregiver burden. And I think that's the crux of what this question is getting at. The main finding in that study was that caregiver burden is mild to moderate upon admission and discharge. And that's in both the home and in traditional hospitalization. And that hospital at home is unlikely to cause what we'll call undue burden on family caregivers. Now that matches a much earlier study, a 2012 meta-analysis that had similar findings. But this newer data is really important given the growing number of hospital at home programs. In addition, there's been a scoping review, it's called, from 2023 that showed that patients and caregivers generally had positive experiences with hospital at home. They reported that they found it professional, integrated, and high quality compared to traditional hospitalization. And some of the studies there highlighted, the importance of feeling secure and receiving safe care at home is a fundamental consideration. I think that's part of where these questions about caregivers come from as well. And another set of those studies showed that patients often tried to avoid placing additional physical and psychological burdens on those family caregivers. The patients worry in many cases about the potential harm to their relationship with caregivers. There are a couple of really important things that came out of this broader review. So they found that to ensure effective hospital at home services, and by the way, this is not rocket science, but it's important to involve caregivers in decision-making and communication with the healthcare professionals, given the very close relationship that's required oftentimes between caregivers and patients. And last but not least, that providing training and support for caregivers to help them both feel less burdened, but also feel more confident in managing potential problems is really critical. So that approach helps to facilitate reliable discussions on things like care planning and promoting the personalized care that many people seek out of a hospital a hospital at home program, any kind of hospitalization. So I'm going to mention just a couple of challenges and then a couple of positive aspects for caregivers themselves. So some of the challenges that have been reported include when caregivers feel unprepared for the caregiver role due to things like limited knowledge and skills. People are scared that they'll do the wrong thing, right? In addition, some caregivers have reported receiving a lot of information from healthcare professionals, which makes it difficult for non-clinical folks in particular to identify what the essential details are. So these come back to the sort of the need for training of caregivers themselves. And particularly if those caregivers have been excluded from the initial decision to pursue hospital at home treatment. And then the last, which is really hard to quantify, but some caregivers may have a difficult time separating their caregiving role from a personal life. But let me end on the positive aspects for family caregivers. So one of the things that was interesting and heartening is that hospital homes sometimes led to stronger bonds between patients and caregivers. And I've certainly seen some presentations between a caregiver and a patient who've experienced exactly that. And overall, family caregivers have really reported, by and large, positive experiences with hospital at home and felt in the end that it was a good choice for them, for their person. And then I'll end on this. Family caregivers frequently value the continuity of care, and the support that's provided by a skilled hospital at home team in a way that they don't have to necessarily go back and forth from a hospital to take care of their loved one. So there are many different variations on experiences, but those are some overall findings that we have learned about, and we continue to want to and plan to study this issue.
Oh, thank you so much, Ronnie, and please continue to point out both those things that are rocket science and all those things, especially that are not. We sometimes miss them when we're delivering healthcare, and the role of caregivers and family is obviously central to so much of what we need to do and how we need to be thinking. And I'll speak for myself, often not doing it quite enough. So really appreciate those perspectives. I was going to ask you a question, but it looks like you're going to ask us a question, Linda. I'll turn it over to you.
No, I just wanted to say one more thing on the caregiver topic, if that's all right.
Yeah.
Which is, I think one of the important things is that generally programs kind of don't have the caregiver do the medical care, right? So still the nurse or the paramedic is coming in to do the IVs, of course, to draw the blood, to do all the things. And what we would want to discuss with the caregiver is, what of your normal activities that you have been doing prior to the hospitalization do you want to continue to do during this hospitalization? Do you feel comfortable still helping the person go to the bathroom? If not, that's okay as well. All these programs have usually home health aides available to support patients in the home. And so it's really just, it's again, like Ronnie said, like that upfront, if we can get the caregiver in the very beginning to help think through what they want to do, at least at that moment, and they can change their mind during the hospitalization. That leads to sometimes the best outcomes.
Well, that's fantastic, Linda. Thank you. And, it occurs to me as I think about University of North Carolina and our 11 hospitals and sort of my role in the healthcare system here. That's where speaking from someone like yourself who's implemented this for a long time would be really helpful. I think that immediately apparent to us is, to some extent, what we need to do medically, what to do with vital signs, data to be gathering, because that's how we think. But not often enough are we thinking about what really is the right way to engage with the caregiving team that's already there, how to empower them, how not to overburden them. That may not be intuitively how we think. And so really appreciate your perspectives on this, because I think it's an area of critical importance for successful, sustained launch. As long as I got you on the hot seat, we're going to keep you there. This webinar is being run by the Center of Excellence for Telehealth and Aging. So we're interested in telehealth. And obviously there's a telehealth component to this, which you've already alluded to in sort of the schematic of the different parts of hospital at home. Can you dive a little deeper into, core elements of the telehealth delivery platform, the training of those who are utilizing it? You mentioned this when you said a lot of providers are not really comfortable using telehealth quite yet, and that might be a barrier. And any ways that you've seen it go wrong in particular, like pieces that could be missing or things that you need to make sure you incorporate technology or training wise to incorporate the telehealth component of hospital at home.
Yeah. I mean, I think an important thing to say is when this started, certainly in the 60s, and even when we started at Mount Sinai in 2014, we did not have a telehealth component of this. I think today, most programs have some element of telehealth, and it can be a on-demand kind of like monitoring of the patient versus some programs do have continuous monitoring. Maybe they're monitoring a heart rate or something virtually. So that's really one divide today. There's some that do full continuous and some who do on-demand monitoring. No matter what, I think the important thing is to have a technology that is, you don't expect the patient or their family in this moment of crisis where they've just come from the emergency room to set it up themselves, right? You have to have a system in place to easily set that up and train them and then continue to train them. I'll give an example. At Medically Home, they wear the PERS device on their neck and every single day we ask them to or the nurses who are working with the patients, ask the patients to test that PERS device because it's scary to push it. And so we want them to test it every day to make sure it's working, but B, so that when they're like, they know what's going to happen when they do push it. And so that kind of practicing is really important. Picking up the phone and then having the nurse to be able to force the video into the patient's home if that patient is not comfortable with the tablet is another mechanism that we have found really useful for some patients. But some are super savvy. They love the tablet. They love to play around with it, see their schedule and call their nurse. We had a patient recently who, never could get the cat on video at the same time as with the physician, and went ahead and just took a lot of pictures on her own, and they're probably all in Epic somewhere now in that health system of that cat. So it is a real variety of people who are comfortable with or not comfortable with the technology. And we've never had a patient at this point who has not been able to interact with it in one form or another.
That's awesome. No, thank you, Linda. It's right. And what I hear you saying is, if I can interpret, and what I interpret from it is part of it is, yeah, there may be better and not better technologies, but what's important is about how you incorporate that technology into how you launch your service line, how you help your patients and their care partners be comfortable with that technology, almost regardless of what it is that you're using. It can't be a barrier. I think of my own older friends that are so nervous before a telehealth visit and reflect upon how we often don't do a good enough job just walking them through that when they're with us in person and what they need to do to lower those barriers. So,
and Kevin, just to build on Linda and Ronnie's comment, the technology is a tool. It is not all that is hospital at home. And as Linda said, decades of work in hospital at home were done really without any technology. When we did our first cases here in Baltimore in the mid-90s, the technology that we had was a pager and the first generation cell phone that you carried on your back. It was sort of a small carry-on bag of the phone itself, and we thought it was a miracle. And we were able to provide safe hospital at home care. I think what the technology now does is it provides added layers of safety, added layers of quality if it can be implemented correctly. And I think it allows hospital at home units to take care of patients that they would have felt uncomfortable taking care of 20 years ago, because now you can monitor a heart rate. Now you can monitor various parameters and feel safe. So being able to go deeper into the acuity of illnesses actually improves the ability of hospital at home to be sustainable.
Awesome. Thank you so much, Bruce. Really appreciate it. I'm going to sneak one more question in before we go to the audience broad questions, because it's so important. What do we know about equity issues and access to hospital at home? And I'm going to send this your direction, Bruce. New care models are often at risk of not being equitably distributed. What do we know about hospital at home, albeit not all that new, it's newly being scaled, and equitable distribution?
Yeah, terrific question. And I think, like other areas in healthcare, hospital at home wasn't particularly focused on equity issues until relatively recently. But there have been a few studies now that have looked at it. We went back and looked at the data from the Center for Medicare and Medicaid Innovation study done at Mount Sinai that Linda and Al Sue led. And we went back and looked at those data retrospectively. We had indicators. We knew which of the patients were Medicaid eligible or dually eligible for both Medicare and Medicaid. And we also had indicators of people living in New York City public housing. So 40% of the people lived in New York City public housing. So at least in that demonstration, in that trial, the notion that hospital at home could only be provided to people living a very high lifestyle did not appear to be true. And most interestingly, Linda noted that in that trial, we saw reductions in 30-day readmissions, 30-day ED visits by about 50%. And when we went back and looked at the data by Medicaid eligibility, by dual eligibility, it turns out that the reduction in readmission and ED visit attributed entirely to the economically disadvantaged population that we took care of. And I think there are a number of hypotheses for that. The one I tend to favor is that I think care in people's home, as a clinician, I think, although I'm not crazy about admitting it, I think I'm a better person when I'm in someone's home than when I'm there attending in the hospital, as much as I try and be a good person in both spots. When I'm in someone's home, I'm a guest. That's their domain, and I'm company. It's sort of like, but when I'm in the hospital, that's my place, and I may act not quite, maybe I'm not as good a person. In any event, I think what it does is that it puts the clinicians and the patient and their family on more of an equal footing if you're on their turf. And perhaps that creates a better therapeutic relationship. Unsure. More work to be done in the space for sure. We also did some work looking at outcomes related to levels of social supports that people had. And there didn't seem to be any difference in outcome by that either. So more work, clearly more work to be done. We're doing some of that with support of the John A. Hartford Foundation, and I'm sure others are also working on this, but it's a really important issue. And also our colleague David Levine has been leading efforts on implementing and scaling hospital at home in rural areas. That's another equity issue. And probably don't have time to talk about it today, but there are some who hypothesize, including some of us, that hospital at home could be a part of the approach to bringing healthcare delivery back to rural spaces. Which would be nice.
Can I add to that a little bit?
Please.
Thank you, Bruce. I'm really glad you mentioned rural, because that was one of the things going on in my head as we think about the various forms of diversity. The only other thing I will add, since you covered that so beautifully, is to point to a really nice resource by the group putting on this webinar. So it's the Equity in Telehealth Toolkit for providers. And since we're talking about telehealth here, and that also fits for hospital at home work, anyone who's on the webinar and interested should check that out.
Awesome. That's awesome. Really interesting data that the measured impact was at least as great, if not greater, for those from disadvantaged socioeconomic backgrounds. Thank you for that. We're going to transition to audience questions now. One has already come in, but more are welcome, at least over the next 5 minutes. The one that came in is basically, what's the strongest argument for continuing or expanding this model within a healthcare system? I'm going to personalize it. So one thing I should do after, I get some sleep is to go back to my leadership and say, why aren't we doing more of this? And then I should have statements that follow that, because we should be doing more of it because ... What have you found, either based on, the evidence or your own experience making these arguments at a healthcare system level, is the strongest argument for putting more resources and support into expanding hospital at home? And I will open it up. It's an all play.
I mean, I'll start. I think we probably all have answers to this, and I'll just start. First of all, we got to first think about our patients, right? So where did it start? This started with geriatric patients. We've already listed all the evidence about that. If we can provide better care that doesn't lead to that, normal road that goes, hospital to SNF, et cetera, if we can break that and have patients do better at home, that's the first priority. But I'll open up. There's many others beyond that.
Yeah. No, I agree with Linda. I was going to answer it in a slightly different way. So Linda, myself, others in the space constantly get calls from health system leaders, and the conversation will go something like, hey, heard about hospital at home, we want to do this. And my first question to them will be, well, why? What problem are you trying to solve? And this is with senior C-suite folks. And to my constant, and actually I'm no longer surprised. About a third of the time, they cannot provide an answer. You know, they absolutely cannot provide an answer. And I think part of that is now, at some level, hospital at home is a little bit of a bright, shiny trend, you know, object, and that gets me a little bit anxious. About a third of the time, they'll talk about problems that they have, like we have a lot of older people in our hospital and discharging them is hard, for which hospital at home may not be the first or best solution. And I'll say, well, have you ever hired a geriatrician? Do you have a care transitions program? Do you have a house calls program, you know, home-based primary care program? And they'll say, wow, we need to think about those too. And then about a third of the time, they'll start articulating a problem statement for which hospital at home can be helpful, i.e., we are in a capacity situation and are contemplating building out a new hospital wing. And Linda noted before, capitalizing a hospital bed, depending on where you are, is usually somewhere between $2 and $5 million. That's a lot of money. That's a lot of money. Or, you know, they'll say we have very high readmission rates. We've already done a lot of the geriatric playbook and we need something different. We have problems that hospital home can actually help with. So I think the issue depends on the stakeholder and what problem they're trying to solve. You know, at a societal level, if you can avoid building hospitals, that will save the system billions with a B. And we just can't build hospitals fast enough. There are a lot of older people coming down the pike, and we're not supposed to use certain imagery that talk about waves of a certain color, but you know, there is a silver tsunami on the way, and we're not going to be able to build our way out of that. So I think hospital at home will become a necessity for many.
Wonderful. And I think that's probably a wonderful place to leave it for today, recognizing that the silver tsunami is one that we should be celebrating and dancing in, given that that's what winning looks like in healthcare. But it's time that our society and our healthcare delivery system catch up with our evolving demographics and help meet our patients literally where they're at. So really appreciate this. I think we're up on time. Thank you again from the Center for Excellence for Telehealth and Aging, which is a part of West Health Institute, dedicated to making sure that older adults also benefit, and particularly benefit from the advances that telehealth helps make possible. Many thanks and have a great Wednesday.